Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians, and people with lived experience
to support your practice in being more evidence-based. Well, hello everyone. Thank you so much for joining us for another episode of the Research Works podcast. I am here solo again today. Unfortunately, poor Ash is not feeling so well, so I get hosting duties today. So I get to ask all the questions as well as a list of questions that Ash had too. And I'm really looking forward to this episode because we actually haven't spoken about this particular area yet. So the topic is interesting, but also we have a guest all the way from Spain. And the last time I had him on the pod was in Slovenia for a conference, and I said your name so terribly. So I'm going to try again now. And you were so gracious and nice, but I need redemption. So let's see how I go. Welcome, Álvaro Hidalgo-Robles. Did I say it?
Thank you. No, that's perfect. That's perfect. I know it's a weird Spanish name.
I'm terrible with, I can't roll my R's. So can you say your name fully, just for the record, because I'm pretty sure I still didn't do it properly. Go for it.
No, it's Álvaro Hidalgo-Robles.
Okay, so that sounded nothing like what I just did. I'm so sorry. And I've been practicing all day. Thank you for being so gracious. That's obviously something that a quality that you still continue to have. Thank you for your patience there. But very excited to speak with you today about a topic that I am so interested in. And this is a paper that you are lead author for, but with a great group of authors, friends of the podcast, Ginny Pallig and Rosalind Livingstone. So the article we'll be discussing today is called Identifying and Evaluating Young Children with Developmental Central Hypotonia, an overview of systematic reviews and tools, published in MDPI Healthcare in 2024. Now, before we get into it all, of course, we love to do a good formal getting to know you. And I'm not going to say your full name again. So I'm just going to say Álvaro just to limit my embarrassment. So let's get into a bit more about you. Álvaro is a pediatric physiotherapist and researcher specializing in early intervention for infants and young children at high risk of neurodevelopmental disorders. He serves as an associate professor at the Universidad Internacional de la Roja. How do I say that? Please help me. Okay, that wasn't what I said either. Yeah, thank you. In Spain, where he's also pursuing his PhD. His doctoral research focuses on the early detection and intervention of cerebral palsy, with a particular emphasis on translating evidence-based tools into clinical practice. Álvaro is also serving on the board for the EACD Early Career Researchers Forum, tasked to support and connect professionals in childhood onset disability research, which I have been so lucky to have you in that role because you introduced me to a whole bunch of people last time. So thank you. And what a great bio, Álvaro. Busy.
Thank you. Wow. Thank you for having me. It's great to be here.
Oh, I'm glad.
Weird, but I feel like a strange need to build Legos because every weekend I listen to the podcast while building Lego sets. So it's been like a ritual for years.
I love
now
that.
Feels so unreal. I'm so nervous to have some bricks.
So next week when you're building your Legos, you can listen to yourself on the podcast. It's a bit surreal, isn't it?
No, I won't do it.
No, you have to listen to yourself. It'll be good. All right. So look, I think this will set you at ease. I do follow you on Instagram and I do love the things that you do. And I sort of know from your Instagram account that you're a big science fiction fan. And I hear you're also a bit of a Star Wars buff. And we've just had May the 4th, as in May the Force be with you, recently. So my question for you today, Álvaro, it's a big question. And there's only one right answer, in my opinion. Which one is your favorite Star Wars film?
Wow, that's a really difficult question. Really difficult.
There's a lot to pick from.
This is going to sound painful for some Star Wars fans, but as a millennial, I have to say the Revenge of the Sith.
Really? Oh, Oh, even Ed has put his hands up in disbelief. But I think, though, Álvaro, what that means is it describes his vintage more than anything, potentially, because I believe that for Ed, it is A New Hope, episode 4, the original one. Why do you like The Revenge of the Sith so much? What is that about for you?
I think it's connected with my infancy. It's a film that I remember going to the cinema, which is like an experience I didn't have with the original trilogy.
Of course, because that was back in the 70s, a long time ago.
I saw that in TV, and I've seen like thousands of times.
Yeah.
But I have like that special connection with the prequel trilogy.
Yes.
And I love it. It's been like 20 years now. This month, I think, since they released the Revenge of the Sith.
Really? That makes me feel old.
Yeah, me too.
See, I didn't, and I love that you appreciate Star Wars so much, and I love Star Wars as well. I love the fantasy of it, but I love the sci-fi of it. I am a huge, huge fan of sci-fi, which I didn't realize that I was. And I think there's something about just the whole, just, I don't know, it's just out of this world, and it's a good way to pass time. And so I love that. And Ed is just making a point for me. He's been very distracting with the computer screen signaling to me because I think he wants to be in this conversation. But he mentions Caravan of Courage. Does that mean anything to you?
Say it again, sorry?
Caravan of Courage, the Ewoks film.
Yeah.
See, I don't even know that one. But look, I think that having something that is a good pastime, something that reminds you of, growing up, it's amazing how nostalgic that can be, hey? But it also tells you how old you are.
Yeah. And really, now I'm like on a mission with my son, with Luca. I'm studying how to introduce step by step in the Star Wars world.
Educating him.
Short story, and we are starting with little pieces.
Perfect. And you can combine that with your love of Lego as well. It's all quite combined.
Yeah.
Yep. I went to a house recently and it's actually in Malaysia, and they have this whole room filled with Lego, but all the big what do you call it? The Death Star, everything Lego. And it's the whole place is filled with it. And I did think, yes, that'll be something you'd be right into. Collectibles, I'm sure. But I'm sure that everyone wants to know what we want to talk about today. So are you ready? We're going to switch now into the topic that is hypotonia. Are you ready, Álvaro?
Ready.
Okay, let me tell you all a little bit about what we'll talk about today. So developmental central hypotonia is a complex and often misunderstood condition in young children, marked by low muscle tone due to non-degenerative brain-related causes like Down syndrome or hypotonic cerebral palsy. So this umbrella review analysed existing systematic reviews and tools to identify the most reliable ways to assess hypotonia in kids aged 2 months to 6 years. The findings? Well, there's strong support for the Hammersmith Infant Neurological Examination, or the HINE, for children under 2. But for older children, no gold standard tools exist yet, and the authors evaluated neuro tools like the MPH-10 and a clinical assessment algorithm, which show promise but still need validation. The bottom line, clinicians need objective and reliable ways to quantify hypotonia, not just observe it. And this research helps chart a path toward more consistent, evidence-based assessment in everyday pediatric therapy practice. So really interesting. It's quite incredible, actually. We talk about hypertonia a lot, and what is missing in a lot of our vocabulary, yet what is so influencing at how a child functions is hypotonia. So, Álvaro, I thought a good place to start is to understand, from your perspective, what motivated you and other co-authors to undertake this overview of systematic review on hypotonia? Because a systematic review is no thing you just wake up and decide to do one day. It's a lot of work.
Yeah, it truly is. Yeah. Well, what really motivated us was you said, right, the gray area we kept seeing around hypotonia, and especially central hypotonia in the clinical reality. Children with low tone, especially those with neonatal symptoms, can be referred to therapy, but there was like so little clarity on how to assess hypotonia properly.
That's right.
And and referral can also lies on observation or single items, and that didn't sit well with us, especially with Ginny and Ross, who have been they have been publishing in this field for decades, and because as you said that hypotonia clearly impact the functioning.
Yeah, that's beautiful. And I think a lot of clinicians will really relate to that, when you look into it, it's just so hard to find anything on it. So before we sort of dive into what you actually did here, I thought it might be really good just to talk about what hypotonia is. Because when I read your introduction, even there you can see there's a little bit of confusion about hypotonia, which is a really broad term. Can you walk us through what hypotonia actually is?
Yeah, that's a key point. Yeah, we're gonna talk a lot about
It's a big question.
today because hypotonia refers to reduced muscle tone, which includes resting tone or like passive tone, the resistance we feel during passive movement, but also postural or active tone, which is the child's ability to hold themselves up against the gravity. And then we have main types of hypotonia. The central one, which originates in the brain or brainstem.
Sure.
It's often in infants born preterm or with some developmental conditions like Down syndrome or Prader-Willi syndrome. And then we have the peripheral hypotonia, which is related to the motor unit, like the nerves, neuromuscular junction, muscles, and there we find, for example, the SMA, the spinal muscular atrophy.
Yeah. So the two, it makes sense, doesn't it? We do need to distinguish between that because your interventions, I imagine, are very different. Like as a clinician, I would want to know, is there capacity to strengthen the muscles? Probably what I'd be thinking. In the paper as well, you also brought up the point about the need to differentiate developmental central hypotonia from other forms of hypotonia. Why is this distinction clinically important from your perspective?
Yeah, this distinction is really important because as you said, the clinical pathways are completely different. If we look at the literature, there are like hundreds of publications focused on determining whether hypotonia has a central or peripheral origin, whether it's from the brain or from the anterior horn cells in the spinal cord. And for a infant with SMA, we have very clear diagnostic pathways and targeted therapies that we need to start early. But for a baby with central hypotonia due to a genetic cause or a brain-based condition, there's no standardized management and there's no consistent way to measure it over time. Yeah, and really we still know very little about the physiology of hypotonia when it originates in the central nervous system. So, for example, transient hypotonia in newborns often improves as development progresses, but persistent central hypotonia is actually a common feature for many neurodevelopmental conditions, such as we said, Down syndrome or Prader-Willi, but fragile legs, autism spectrum disorder, Joubert, many others. Central causes now is make up 60 to 80% of the cases. So that's a lot.
Yeah, that's really interesting. And when you think about that, you mentioned there about the lack of standardized or tools to evaluate hypotonia. When I think about it, it makes sense because we often talk about we're very subjective in how we describe it to each other. We'll just say, we don't have a spasticity measurement where we can say to someone 2 and you go, oh, I probably know what that feels like. Whereas hypotonia is very much floppy, but then there's different forms of it. Sometimes they're really active. They can be active, but then it goes again. And it's so variable. And when you're trying to teach students or new clinicians about what hypotonia is, I don't have a consistent language that I can use to describe it, but kind of going, oh, it's low tone, the low muscle strength. Why do you think this gap has existed for so long? Given how much work we've done in hypertonia, why has hypotonia been left behind? What's your thoughts on that?
That's such an important point, and I think a big part of the problem is that central hypotonia is still not well defined, or is still not fully understood.
Okay.
We use, as you said, all time in clinical settings, the baby is floppy, she or he has low tone. But when we dig deeper, we realize we might be talking about different things.
Yeah.
Most clinicians are referring to decreased resistance to passive movement, but that's only part of the picture. And we know it's, as you said, really subjective. And others are thinking on the child's ability to move against gravity, and some might be thinking or including things like ligamentous laxity.
Yeah, that's a big one.
Yeah, at the end of the day, we are using a single term to describe a whole set of signs and behaviors that are not necessarily the same time. And this lack of, let's say, operational definition has huge implications. If we cannot clearly define what we are looking at, hypotonia often ends up as a kind of background feature. We write in the report or in the clinical history, but we don't really have the tools to follow up on.
Yes.
And in that context, it's so hard even to agree on what a specific intervention should look like, for example, depending on hypotonia severity.
For sure. And I can see that if we can't measure to even describe it at a baseline, let alone to describe what might happen after an intervention, of course we don't know what interventions will work because we don't have the means to say this worked, apart from a subjective description or a feel, which is very different based on how many years you might have been a clinician for, or how many kids you might have had on your caseload that has hypotonia as a broad term. So it's interesting, isn't it? And I often think about cerebral palsy registers, and I think you mentioned in your paper as well, some have hypotonia in them, some don't. So are we capturing that information too?
Yeah. Regarding hypotonic CP, we have now with the new the proposed definition and some other beautiful papers from, for example, from Dr. Puma. We have a little of controversy because, for example, half of the register are including hypotonic CP as part of the register, but as the other half not. So I think the first important step is to get that definition, to really know and consensus what are we talking with we talk about central hypotonia.
Yeah, for sure. And I can see why you would want to embark on this systematic review to see what is actually out there. Talk us through a bit about this review now into the methodology. So this was an umbrella review. I love a good umbrella review. And when you start there, you're trying to look at it big and understand what is out there. Can you tell us a little bit about, why you chose this umbrella review and what was included and excluded from what you wanted to review?
Yeah, sure. An umbrella review is a type of systematic review that synthesizes evidence from other systematic reviews or meta-analysis. And instead of looking at individual studies directly, we included systematic reviews, evidence synthesis, and articles describing these potential tools or approaches for assessing hypotonia. And we thought it was a valid approach at this point for this topic because hypotonia has been looked in many different ways, sometimes through assessment, sometimes through neurological exams, maybe as part of specific conditions like Down syndrome. And we wanted to bring all that evidence together to compare findings, identifying the common themes and the gaps, especially for developmental central hypotonia, which hasn't been the main focus in most reviews so far. And we ended up having 3 systematic reviews, an evidence-based algorithm, 3 measurement protocols, and 2 assessment.
Wow. I mean, that's actually pretty good to review, but also it's not a lot as well, isn't it? Given all the time that's passed, and this is what you could find. It's interesting.
Yeah, with the inclusion and exclusion criteria we use, we focus on reviews that look at children from 2 months to 6 years with central hypotonia, non-degenerative, like brain-based conditions or genetic syndromes. And the aim was, and that's also an important point of the paper, that to include tools that could realistically be used by occupational and physical therapists or pediatricians or clinicians in the community setting. So we excluded tools that required specialized lab equipment and couldn't be implemented in typical home or community therapy settings. For example, the electromyography or 3D motion analysis and so on.
I did see that. I thought that was a really interesting thing that reflects the heart behind the authors being clinicians. You know, if you want to put this into practice, and it included 3D motion analysis, which not many people would have access to. It still goes, well, so what? How do we actually look at it? I thought that was a really interesting exclusion criteria, and I love that. It's really great.
Thank you. That's, as you said, part of above all Jeannie and Ross are, and they give the paper that clinician sense that I think is really, really important for clinicians that read the paper.
It really does. And I think it just reflects again, you know, the role of a clinical researcher. I heard recently someone said to me that, you know, the clinical researcher, it's a dying breed. You know, it's because it's so hard because, you know, you need to be associated with the university and then you've got your outputs, but you're also a clinician. And then how do you find funding unless you're part of these bigger projects? It is actually very challenging. And yet a lot of the work that we need to implement, when you think about the barriers to implementation, it's often because of how do we get that information to the clinicians. So being a clinical researcher has so many benefits, and I can see already that the tweaks in this review really demonstrate that this is for clinicians, which is fantastic, absolutely fantastic. So within everything that you have found, there's a lot to unpack there. So let's go through it one by one. Now, shall we talk about maybe the hind first? Because that came out quite strongly. Talk us through the result in this review and how it relates to the hind.
Yeah, the hind was the only tool we identified with solid psychometric properties, psychometric evidence for infants under 2. And importantly, as we said in the definition, it looks at both active and passive tone. There are like extra few good things about the hind 2. It's simple, accessible, and it's already widely used in CP detection. We know from research that around 25 to 50% of early intervention providers are using it in practice. So it's practical, and it's, again, a real-world choice for clinicians working with hypotonia. One important point we emphasize in the paper is that we need to administer the full hind following the standard and the official proforma from McKeith Press. While we do suggest 14, I think they were 14 items that may be relevant for screening of children with a developmental central hypotonia. They are based on the results of literature review and analysis only at this point for the moment. And we make it clear that all tools for assessing children with central hypotonia still need to go through rigorous expert consensus and validation. And thankfully, some of the studies are already underway. So this is a work in progress. And our goal with the paper was really to open up discussion and research with the academic community and highlight the potential role of the hind in areas where clinicians lack validated tools.
That's beautiful. So if I understand that correctly, you've got the hind, which we use a lot for, identifying children at risk of cerebral palsy in combination with obviously, medical imaging and general movements, for example. So that is part of the assessment battery. And you're saying that there are some items there that you can use more as a screen for hypotonia within hind. Is that correct?
Yeah.
Great. So if we use it as, for those who need to understand maybe the hind and the screening, can you still get a score out of the items that you selected that could be good for a screen for hypotonia?
Yeah, we don't have at this point that score. I think we are developing some research project. Maybe we are close now to have something like this. But that's an important point, as we said. And I think Ginny and Ross and pre-governor will agree with me that if anyone is using this tool, is using the hind in practice, and can please share with us your feedback, write up a case report or post your experiences on social media. I think that's important for us at this point, because that's how we move the field forward.
Yeah, I agree. I love that it's like an invitation to all the clinicians and the researchers in the academic world to go, hey, this area is really important. We don't quite understand it well enough, and potentially our definitions will be influenced by some of these assessment results as well, which is where we need to work toward. Is that right?
Yeah, that's it. Yeah, and I think, for example, within the hind, we can many clinicians that are listening to us now can think about many items that we usually use to assess hypotonia, like for example the scarf sign or
can we go into those? I was going to ask you that next, because we're quite used to doing these few assessments kind of a little bit random. They don't belong to any tool. Can you go through that one by one? Let's describe them each, because they're all named very much like how it looks. So the scarf sign, can you describe what that is? Because it's something that we often talk about with hypotonia.
Yeah, it's an item which is also included within the hind, and you need to take the arm of the baby and pull to the other side. And you feel some kind of resistance, and you'll see where the elbow, in this case, puts like in the within the body. And then with the hind, you can score that from 0 to 3 points. And we have like certain points we will get if you have low tone in this particular item, which is completely different of having high tone or typical tone, let's say. And this, I think one important thing of that is that these classic signs are widely used and consistently show up in both clinical practice and we also saw that in literature. And really important point when we talk about the hind, and we said that it has like the better psychometric properties, is as you said before, the subjectivity. The reliability really depends on the therapist experience and consistency. For example, one study we reviewed within the umbrella review showed that inter-rater reliability for these signs was only moderate overall. But after 6 months of training, it improved substantially. And that tells us that these signs can offer valuable clues, but we need their use as a part of a structured, systematic approach.
Yeah.
And without that, I think there's an increased risk of variability.
Yeah.
I can think we can, we can actually take a good lesson from implementation studies on tools like the hind, because even though these signs might be part of the routine pediatric exams, we know from research that they are less consistently registered unless we include it in a in a formal tool.
In our standard assessments, you're right, yeah.
Yeah.
So I can see there that in the paper you have published, the proposed and highlighted the screening for hypotonia, which does include a lot of the things that we often would think about for hypotonia assessment. Because the other one is head lag. Can you talk us through what head lag is, what it looks like, and go from there?
Yeah, that's something that I think most pediatric routine evaluations try to test, and that's we call it like the pull to sit.
Yeah,
trying to get the child from supine to sitting to a sitting position, and then we observe what the head is, and that's an important point of what we call the active, the active tone within in hypotonia, not just the decrease resistant to passive movement. And we have all those kind of items within the hind, so we have like a better picture of hypotonia.
Sure. And is the other one, is that the hip abduction range? That's more your passive elements?
Yeah, that's it. Yeah, we open the legs and we see the angle between both legs, and we expect that in hypotonia we'll have like a larger angle than when we have typical tone.
Yeah. Can we distinguish between joint laxity and passive and the passivity of the movement when we do that? Or do we have to assume it could be a combination of either?
Yeah, it can be a combination, and but the important point there is we can have, as we said, like a combination of different things, and both can be represented within the central hypotonia. For example, another thing that we can actually hear a lot is the weak muscle. Even they can be within. A child with hypotonia can have a weak muscle, but hypotonia isn't just about softness. And actually, for example, in central hypotonia, strength is often near normal. I would say that it's more about how the child moves against gravity, how they sustain their posture to play, how they move through space, how they interact, feed themselves, all these meaningful everyday activities.
So that's really interesting to me because, what we've often been taught at university is W-sitting, for example. And if you W-sit, what does that mean from a tone perspective or a joint perspective? But a lot of the times children will sit in W-sitting because it gives them more stability for function when they're sitting and playing. In the context of this paper and talking about hypotonia, how do we interpret W-sitting? Is it a sign of hypotonia?
Yeah, it is a sign that it isn't within the hind, but it appears consistently on the literature as a sign that we can see in children with hypotonia, and I think it's totally, as you said, totally functional because they help this child, these children to play in a position, in a, let's say, more stable position.
Yeah.
So I think one of the and you said also one of the biggest traps that as clinician we can fall into is that thinking I don't know how to say, like intervention should aim to change the tone itself. We have seen this kind of approaches. Yes,
we have,
but we don't want to. We don't want to jump in just because the muscle is feels soft or there's low resistance or there's W sitting. We really need valid and reliable ways to measure hypotonia, but not so we can fix the tone itself, but to set realistic goals linked with outcomes we can measure and understand how it plays with a child's participation.
I love that you've said that, and it has triggered me to think about, this is common, right? A goal is to improve head and trunk control. And when you say that the fixing of postural tone, it often does come down to that, particularly with your GMFCS level 4 and 5, who tend to have more hypotonia in their trunk. How do we contextualize this for families or for clinicians who are writing goals and wanting to set goals around improving head and trunk control when hypotonia might be the main contributing factor to that, but we can't change hypotonia? What do you have to say to that, Álvaro?
That's a great question. That's a great
tough
question.
One. Yeah.
Yeah, we have just published an overview review about the interventions. So we have approached that question recently. And in terms of therapy, we looked at OT and PT interventions for children with hypotonia, and I say the take home message for that is like we do have positive evidence, even if it is low or very low quality, not just to focus on the tone itself, because with the evidence we have, we cannot know if we are changing the tone or not. But we can promote child active routine-based activities, and we know that it has even low or very low quality, a positive result. And that means things like time, like early sitting, like supported stepping and standing, like treadmill training, sensory motor play, aquatics, strategies like infant massage, and that important parent-infant interaction that also give us the infant massage and orthotics. So there are many things we can focus on.
Yeah.
Jenny made a beautiful graphical abstract about it, so I highly recommend checking it out.
Yeah.
But I think it's important. Even we can say the tone is like a body structure and body function theme. Not just looking at the tone itself.
Looking at the big picture, isn't it? And I think more and more, what a lot of the research is saying, what we've been called to do as clinicians is, we still acknowledge and note the body structure and function impairments, but we have to understand what it is that we can modulate and change. And if it's a centrally driven hypotonia, what's realistic to change. I think having those conversations are important. And I'm a big fan of using supported stepping devices or walking frames, getting kids upright against gravity for those opportunities for strengthening. But it is a very developing area at the moment, isn't it? And I think it's having those conversations with families and going, okay, look, yes, this is a good goal for interaction and engagement. Not saying it's not important. Having your head up to be able to see what's happening is great. But let's look at all the different tools we can use. So yeah, that leads into your other paper, I'm sure. Let's move into a little bit now. We talked about Hein, and this is for children under 2 years of age. What about kids who are older than 2? What did you find in your review that we can possibly use, Álvaro?
Yeah, we have a key gap there. The Morgan-Paley Hypotonia 10, the MPH10, is a screening tool that was designed by Ginny Paley and Andrew Morgan, and we can use it for older children, and it combines 10 clinical signs commonly used to identify hypotonia. It's like the designed to be quick, practical, and it provides also cutoff score with recommendation for referral to a specialist evaluation where appropriate. But it still needs full psychometric validation before it can be recommended widely. But it's really promising. Like for example, the other tool we saw that was the clinical algorithm developed by Pri Govender and colleagues in some beautiful paper. I also highly recommend it to read them because it combines the clinical history taking with posture assessment, with anti-gravity testing with movement and observation of movement and function. It's not a score, but more a structure that help us and helps clinician reasoning through the assessment of children with hypotonia. And again, more research is needed, but it's a good starting point. And the exciting part of this is like both Ginny and Priya are already thinking and working to expand this option for children over 2 years.
I like that. I went and had a look at both of them. So the MPH10, which is published as an appendice here in your paper, and it does go through, it's an ordinal scale, and it goes through items like vertical suspension, prone suspension, head lag or pull to sit, and hip abduction, scarf sign, all the things we just spoke about, and rating them on an ordinal scale. And I really like this from the perspective of giving me something structured to look at in a systematic way, rather than go, I think this child has hypotonia. They're a bit floppy, like the language that doesn't help to quantify and develop action. And then I had a look at the clinical algorithm, which is very good as well, and that's freely available. I can put a link for that for everyone to have a look at, and you can just go through each of the steps to understand what you might need to look at next. So it's really nice that you found those two tools for kids that are these are all above 2. Is that right, or is there a top end of how old they can be for you to use this?
No, I don't think so.
Okay,
I don't think so.
Okay, that's good. So we should have a look at that then. Yeah. Okay. So I guess from a clinical implications perspective, so you're a physio, you're an OT, you have a child that you suspect has hypotonia, and you're in a community setting. Walk us through what's the best practice approach, based on your findings. What should myself as a clinician do?
Yeah, overall, and based on the paper results, the message could be something like use what we have. As you said, structure your assessment the most as possible. Use standardized tools and focus on function and participation. For infants under 2, the most supported tool we have is the HIND, which is simple, quick, and give us a way to look at both passive and active tone, scarf sign, facial expression, kicking, all things that we know are often affected in kids with hypotonia.
Yeah.
And plus the HIND give us a cutoff score that can help identify children at risk with CP or developmental delays. And I should also, we would always recommend using a standardized motor assessment like the Peabody, the AC2, Alberta Infant Motor Scale, the TIMP, depending on the child's age or your preference or your own experience, because they can help quantify motor delay and support decisions around intervention planning.
Perfect. Because the assessments that you just spoke about, that you identified here, the MPH10 and the HIND, are really more sort of body structure and function, aren't they? So you're saying to do an assessment that's very activity-based. Is that what you mean?
Yeah, but I think the MPH10 and also the clinical algorithm has
more activity.
Many things from activity.
Okay, So the combination still would help us to understand what we can do to develop interventions. Okay, now that sounds like a really good approach. So you kind of alluded to it a little bit before in terms of what's next. It sounds like you've got a few projects on the run, Álvaro. So what are the next steps now for this area of research? You've done the hard work in identifying some measures through this umbrella review. What's next?
Well, as we said, this is a working project. So the step will be to validate the tools we already have, especially the promising ones like the HIND, the MPH10, the clinical algorithm. And that means proper psychometric testing, expert consensus, and real-world implementation studies.
Yeah.
More collaboration between researchers, clinicians, and people with lived experience, including case reports, feedback, shared experience. So we can refine tools that are not only, and I think that's the most important thing, not only valid in terms of stats, but actually practical and usable in everyday settings.
Yeah, that clinical significance.
Yeah. And we also need, we talk about it, no, a clear definition for hypotonia, so that clinicians and researchers are all speaking the same language.
Yeah.
And then that's like a particular area that I feel is really, really important, that I feel it really needs more attention, is, for example, developmental trajectories and severity in central hypotonia. Not all hypotonia looks the same, and having ways to identify severity could help us to predict trajectories, guide intervention.
I love that.
So
Yeah.
improve communication with families, and if we could reliably distinguish between, I don't know, mild, moderate, severe hypotonia, we would be in a much better position to tailor support.
Perfect. I mean, when I think about the podcast episode we did recently of Professor Gareth Bainham, who specializes in rare disease, and we know that, rare disease, cerebral palsy, they're very related, and hypotonia does appear in a lot of children. And we talked a whole lot about clinical pathways, clinical care pathways. And if we can understand it better and go, okay, for a kid that presents like this and this, go forth and do this for the best outcome. And I think what you're saying there really resonates with so many clinicians that want to do the best for their kids. We just need to be able to assess and do all that a whole lot more. Our final question, though, on those assessments you mentioned, do we need any formal training for it? Can we read what you've got in the paper? Is that enough? Or should we do specialized training for the HINE, for example? What are your recommendations on that?
Yeah, that's a great point. I think one of the beneficial things of having this kind of items integrated in the HINE is like we can be trained, we can be calibrated. So a silly example, but for example, let's say based on my own level of experience, I trust more head lag than a scuff sign. Maybe I just feel more confident using it. But if I'm using a structured assessment like the HINE, I don't get to choose based on preference or habit. I assess all the relevant signs in a standardized way. So that not only improve consistency across clinicians, but also, as you said, gives me the opportunity to be trained, to be calibrated.
Wonderful.
Which is really important when we are trying to reduce subjectivity and make assessment more reliable. So I think that's a really important matter when we approach these items.
That is such great advice, and I think we'll look ahead for that. So for all of our listeners, look, I will put this information, this paper, a link to the clinical algorithm. The appendix already has the MPH-10 there as well, so you can have a look at that. And really just inviting people to have these conversations. I'm going to bump Ed's section here and talk to you about EACD, because we are headed to EACD very soon. And that might be an opportunity for people to speak with you about this. What do you reckon?
Yeah, we have pre-conference workshop about this on, if I am not wrong, Wednesday, 25.
Oh, I thought it was Tuesday. Yes, Wednesday. It's a very comprehensive conference proceedings, isn't it? Yeah, there's a lot to pick from. What else? I guess if people are going to your instructional course, which is, here's a bit of a pitch for it. Come on, everyone, let's go and have a look and listen to these wonderful speakers, but also maybe have your input on using the HINE. Would that be an opportunity people can ask you questions, Álvaro?
Yeah, and for example, the question on the final part of the pre-conference, we are planning to discuss a lot. We know this is a very preliminary work. We know there are many things that need to be done. And also, I think, as we said, for us, it's really, really important the feedback we can get from people that have been many years working with people, with children with hypotonia, and having the opportunity of talk with all them, to interact within the workshop, to make this feel bigger and to push it forward together and to work in a definition. I think that's really exciting for us. And we have I think it's 90 minutes that will be so short, but we'll enjoy it.
It'll be a great opportunity. And you're headed up a lot of the early career researchers forum as well. So you'll be actively bringing people together. What kind of events have you got organized for that, Álvaro?
Yeah, we are. I think we will announce them so soon because we have some exciting seminars regarding the early career researchers.
That's great.
We will have beautiful keynotes in a section. We always try to give early career researchers different backgrounds and different experience, senior experience, younger.
Yeah.
And I think that's all about not feeling a lot. I'm still finishing the PhD, and one thing that I need as a PhD candidate or PhD student is having these common conversations and having this, let's say, of the community. And I think if anyone want to join the early career researchers, we will be there. We will have funny stickers and things to recognize ourselves.
Okay, fantastic. Are you allowed to tell us who the keynotes are, or is that still secret?
We will announce the because we're like in the final step to finish with our keynote speakers.
Okay.
And I think maybe this week or the following week we will show it in social media.
Wonderful. Okay.
For the conference.
We'll keep a lookout for that. Unfortunately, I think I've actually just ticked over from not being an early career researcher now. I'm now a middle career researcher. It's been 10 years since I did my PhD, but I haven't really worked as a full-time researcher. I've been maybe a day or two a week, but when I actually calculate it now, I think I've pushed over the 5 years. So yeah, a bit sad. I can't join you guys. I might just come for the dinner still. I'll just join in. Make me feel a bit younger, even though Star Wars, the early ones are probably more my favorites because of the originality and based on my vintage, born in 1981. So
one important thing to say is that age doesn't matter.
There we go. Thank you.
That's the most important thing. I think as we say that, no, if you really think about yourself as an early career researcher, and I think I will be an early career researcher from the next, 20, 30 years, you can join
fantastic.
The
I'll be there with you. I feel like I still need to be amongst all of you. It'd be fantastic. Because the last time I remember we had a good meal together. We had Mexican food in Slovenia, I think is where we went in the end. So we really encourage everyone to come along. It's such a good opportunity to meet people from all over the world, have great conversations, and have a drink or two as well. So I think it'll be fantastic. Álvaro, thank you so much for joining us today. You represented your team beautifully. I know they'll be very proud of you, and you taught me a lot today as well. So thank you. And I'm really looking forward to your pre-conference workshop as well.
Thank you so much from the heart for having me, Dana. It's been a great pleasure. As the biggest fan of the podcast, I was so.
And it's not so bad when you come on the podcast because it's just chatting to me. So it's very easy. It's fun. It's good, isn't it?
Yeah.
Well, to all of our listeners, I hope you really enjoyed that. There's so many take-homes from this, and I love research that have this real clinical implications to it, which is, just fantastic for our implementation. And I know Ash would absolutely love to have been here as well. So hopefully I've asked all her questions properly. For links to this paper, as well as the algorithm and things that we're talking about, head to researchworks.net. And there's also a CPD form there that you can fill out as well as part of your CPD requirements. But for now, thank you very much. Enjoy the rest of your day, Álvaro.
Thank you so much. Have a nice day.
You too. And to all the listeners, I'll talk to you all again really soon. Bye.
Bye.